Thank you so much all for being here in person and virtually. We do have a nice crowd. It appears joined via Zoom, so the audience is large. I love Research Day. I think this is a great opportunity to gather and celebrate the many accomplishments of the talented individuals in this department and beyond. And it is really my pleasure. We have a fabulous keynote speaker today. I do want to thank, there are many people who made this happen, David Kushner and Manish Patankar, both of whom are not here today. Dave is taking care of women in Wausau, and Manish is on a well-deserved vacation, but they did the lion's share of the heavy lifting, along with Autumn Hayes and her tremendous team. So thank you to them for making this happen, and of course to our presenters today. Research can be one of the most Sisyphusian tasks a physician can face, and I'm in awe of some of the presenters, all of the presenters today, truly. So we do have our keynote speaker today. It's Dr. Jeffrey Peipert. He's the Clarence E. Ehrlich Professor and Chair of Obstetrics and Gynecology at Indiana University School of Medicine. He is, in addition to being board certified in obstetrics and gynecology, has a doctorate in epidemiology and has conducted numerous landmark clinical trials. You might know some of them. He's the principal investigator of the Contraceptive Choice Project, which recruited almost 10,000 women and followed them to 2 to 3 years for contraceptive effectiveness, satisfaction, and continuation rates. His research interests are family planning, STI prevention, and public health. I cannot think of a better time to have a more accomplished speaker here with us. I'll mention one more time for CME credit, VUC, VAC, 608-260-7097. Please join me in welcoming Dr. Jeffrey Peipert.
Thank you for that kind introduction and welcome. Happy to be back in Madison. It's a wonderful city. And my wife is from Minneapolis, St. Paul, and said to me recently, I don't want to move again ever, but if I have to move somewhere, I'd move to Madison. So that's a nice compliment. And welcome to everybody on Zoom. I think I may be in a...
Okay, now turn.
Okay. And I would like to say congratulations. I understand Resident Research Day has happened, so congratulations to all the residents and fellows that have completed that. And I'm thrilled to be here on your research day. I will also say I'd like to honor your retired chair, Dr. Rice, who was incredibly helpful to me in my career as I negotiated for my chair position at Indiana. And she was incredibly wise and thoughtful, and best thing she told me to do is get a coach. And I thought that was terrific. So happy to be here. Again, congratulations. And this is a tough time in our lives, in what's going on nationally, both in terms of senseless killings of young people and in terms of the Black Lives Matter movement, and just a very unusual time. It's a time that really makes you have to think about yourself, your goals, your personal desires, how you can be happy. Everything that's going on in family planning with Roe and the Supreme Court decision really has shaken the core of many women's health providers and people who are specifically trained in this area. So it's a tough time to think about wellness, but you have to all the time. And I think it's something that my department struggles with. I struggle with helping people with wellness. It's not an easy thing. It's not here's one thing you can do to make your life better. There's many things, but I'd say the one thing I would learn is, or try and do, is try and be grateful. And it sounds a little cliche, but I would say be grateful for whatever it is you're grateful for. And I'll tell you, I'm very grateful for my family, my wife, my 4 kids. I'm just very, very lucky. The other thing I'm grateful for is that about 4.5 months ago, I was in the ICU at the Cleveland Clinic. I had a bicuspid aortic valve. It was leaking badly, severe regurgitation. My aorta had ballooned out. There was no way to repair it with a transarterial catheter approach. So I had open heart surgery. And now a little more than 4 months. And I would say it was as good as it could be, a wonderful experience. 4 days in the hospital, and I feel like I'm back to normal, back on my bike, back swimming, back staying active. And I'm incredibly grateful. And I think it's a time where you have to think about all the terrible things going on in our country, but try and find something to be grateful for, and do your best to stay well and take care of your friends, and think about your own healing circle, which is something I learned about through my surgery, and we need to think about all the time. So let me walk through the objectives of today, and I'd like to, the residents are here, I'm guessing? How many of the residents have heard of the Contraceptive Choice Project? Oh, you just put my residents to shame. Don't tell them I said that, but I'm amazed that a lot of people haven't heard about it. I'm going to tell you a little bit about it to set the stage for what we're hoping to do in Indiana. And with what's going on with our government in terms of women's reproductive rights, contraception is going to be even more important than ever to maintain health and for public health. So I'll talk to you about the key findings of the Choice Project, describe how improved access to contraception can reduce health disparities, and talk about the Path for You project that we're trying to launch now in Indiana. And I'd like you to be able to list 3 approaches that are unique to this project, the Path for You project, compared to Choice. Some financial disclosures. I do get grant support. It's interesting, in the Choice project, I begged all the pharmaceutical companies to help us. Not one of them provided any supplies. So fortunately, we had a very generous donor, and we were able to pull off our project with a lot of research support. On the Path for You project, these 3 companies have all provided long-acting methods. I think once they realized from Choice the power of science and showing how effective these methods are, they realized we need to spread the word to others in Indiana. So they're providing some LARC methods. And I serve on an advisory board for Ocon, which is a healthcare pharmaceutical company in Israel that makes a very interesting contraceptive device that we may see in the future, very different than the T-shape we have here today, we have in the United States today. So the public health problem is we still have many, many unintended pregnancies, and about 50%, more like 45% of pregnancies in the US are unintended, and roughly half of them end in elective abortion and half end in unintended births. And unintended pregnancies, we've known for many years, are high-risk pregnancies. Unintended pregnancies are either mistimed or unwanted. And the risks associated with unintended pregnancies include increased infant and maternal mortality. Women are less likely to seek early prenatal care, more likely to be exposed to harmful substances. The children of these pregnancies have higher morbidity and mortality, higher rates of abuse, insufficient resources. And in terms of the mother's relationship with her partner and her child, there's more abuse, there's more dissolution of the relationship, high school dropout, and impaired career advancement. So we've known about these risks for many years, and we still struggle as a nation with how we can reduce unintended pregnancies. So this is some good news. The rates among US teenagers of unintended pregnancies and birth rates, and in general, about 80% of teen pregnancies are unintended. We've seen a remarkable decline over time in terms of unintended pregnancies. And there's several reasons for this, we'll touch on them, but access to contraception, I think, is a very important one. So how do we do in the US compared to other countries? And I would just ask you to focus on the US here compared to, let's say, Sweden. And I'd say we're pretty bad in terms of rates of pregnancy, birth, and abortion to US teens. What do you think are some of the reasons? This is the time where I'm asking for resident or audience participation. Help me out. Why do you think we are so bad compared to other developed nations? Great. Yeah, don't teach about sex. Others. Yeah. Access. Yeah, education access. You're hitting on key points we'll get to later in the talk. What else? Yes, sir.
Racial disparities.
Racial disparities. When we look at other countries like Sweden, they don't have great racial disparities, and they don't have as much of a racial and socioeconomic mix as we do in the United States. So there's many reasons why we are worse than other, but you've hit on many of them. But one key one is that in other countries, there are clear and unambiguous prevention messages that start early. I always tell the story about I delivered my first child, Ben, who happens to be a third-year OBGYN resident now, applying to fellowship. I delivered him with a real obstetrician behind me, just in case I messed up. It was a beautiful and easy birth. When Ben came home, I changed his first diaper, and I said, it's time to start talking about condoms. I don't think it's ever too early to start talking to your kids about sex and contraception. So clear and unambiguous prevention messages. By the way, Ben doesn't remember that conversation. I don't know why. There's an expectation that childbearing will be delayed until adulthood. There's not an expectation that people won't have sex, which seems to be where we're hung up in the United States. Greater access to reproductive and contraceptive health services and comprehensive sex education. This whole concept of abstinence education is really crazy as far as I'm concerned. And here's just touching on some of the data in terms of health disparities. You can see that unintended pregnancies are clearly correlated with poverty. If you look at levels of poverty, as wealth goes up, less poverty, we see lower rates. So it's clearly based on income, and it's also based on ethnicity and race. So here you can see broken down by income status, much greater rates of unintended pregnancies in the poor women, poor couples, but even broken down by race, you can see great disparities between Black, Hispanic, and whites. And much of this is all about access, social determinants of health, and just ability to get methods that they need. And that's what was really remarkable when we did the Choice Project. I'll tell you about that in a little bit. So another question for the residents or anyone. What are the most common methods of contraception used US women? Well, let's say the most common. Yes? Pills. Pills are up there, but not the most common. Say it again?
No contraception?
No contraception. No, that would make it a trick question, but of women who are contracepting, what is the most common method? Sterilization. I heard someone say it, sterilization. So it's not just, it's female and male sterilization, but if you look here, 28% female sterilization, then pills, then we can see condoms, and IUDs now have crept up on the list, which is great. Actually, I think it's even higher than this based on the most recent data, which is a good trend. We'll talk about that. So sterilizations is an overused method, in my opinion, in the United States. There's a level of regret, especially correlated with young age, when we have great methods that can last a long time that are easily reversible. And here you can see the typical use first-year failure rates for methods. And you can see in the yellow box, the long-acting reversible contraceptive methods. And you'll see DEPO is also listed in there. But as you know, the key to DEPO is to continue to come back and get the method, which many, many women do not. So I can't put it in the same class as the other long-acting methods, the IUD and the implant. So first, I'd like to just touch on a few myths and misconceptions about intrauterine devices. And actually, for contemporarily trained residents, you don't hear about these anymore because they were back in my day or the days before even I was a resident. And one is infertility, infection, pain. These are common, and cancer are common myths and misconceptions. And the early IUDs, and there was one specific bad IUD that did harm and gave all IUDs a bad name. So when I was trained back in the 80s, 1980s, very rarely did we put in an IUD. Women were afraid of it, and so were providers. There was a fear of litigation. And there was a very negative attitude towards intrauterine contraception, and that's really changed. And there's always been a struggle with the upfront cost of IUDs. So this is the IUD I alluded to that did some bad aspects to the reputation of intrauterine devices. The Dalcon Shield, which was introduced in 1971, even the design of it looks nasty. But the design defects were not only the IUD itself, but the multi-filament string. Any of the residents I see, anybody ever see or hear of this? No, okay. This was an IUD that was used. It was actually didn't go through a formal approval process, to my knowledge, that we have now. And it resulted in a number of infections, increased pelvic inflammatory disease, spontaneous abortions, even deaths due to the IUD. And it was pulled off the market just 3 years after it was introduced and gave all IUDs a bad name. We know that today's IUDs do not cause PID. PID incidence in IUD users is similar to the general population. The risk is only increased slightly just around the time of insertion. And my guess is you haven't seen, most of the residents and people in the room haven't seen a lot of PID related to an IUD use. Or if a woman comes back with pain with an IUD in place, often she's labeled as having pelvic inflammatory disease when it could be another cause. It could be a partial expulsion or something else going on. It's really pre-existing sexually transmitted infection at the time of insertion that increases the risk of PID with IUD use, not the IUD itself. So these data show that the rate of PID just after insertion within the first 3 weeks is slightly elevated. Again, 9 per 1,000 women years is not a high rate, but it's slightly elevated compared to the 1 per 1,000 that we see after this first 3 to 4 week period. And this was a study by a colleague, David Eubacher. He published in the New England Journal that finally factored out the confounder of chlamydia. Now, when you look at IUD use and infertility, you must control for sexually transmitted infections, especially past sexually transmitted infections like chlamydia. In this case, he controlled for chlamydia, and odds ratios of 1 imply no increased risk. This is the IUD when you control for chlamydia, and this is chlamydia, an increased risk. So what's important in terms of research is you have to control for other infections when you're looking at the relationship between IUD use and infertility. And this was a new study from or a new analysis from the CHOICE project where we did just that. The David Eubacher study was a case control study.
Just a minute.
I'm sorry.
She's cuddling. Now she's coming. If you call her.
My Just because I said it about forgetting to hit the mute button, you decided to mute me.
Okay, you should be good.
Okay, I think I'm going to go back. Okay, yes. So what we did was an analysis of the CHOICE data. The Eubacher study was a case control study, which has its methodologic limitations. We did a prospective cohort study. We looked at the women in the CHOICE project who then stopped their method to try and conceive and looked at how long did it take them to conceive. With the hypothesis was that there was no difference with IUD use versus other methods. And actually, you can see here that the median time to conception, I'm not sure if my pointer's working anymore or I'm missing it. The median time to conception was 5 months with IUD use and over 7 months with other methods. But then we looked at other STDs and we compared the STDs. You know that chlamydia is related to time to fertility and infertility. Well, we looked at another organism, Mycoplasma genitalium, and we actually had serology for past infection. And we found that Mycoplasma was a greater predictor of infertility than even chlamydia. So this is important because, one, should we be screening for Mycoplasma? I wouldn't jump the gun yet. I think because this is a secondary analysis of a secondary outcome, we need to validate this finding. But it could be that this is an STD we need to screen for, could be, to reduce infertility in women. Back to intrauterine contraception, most candidates are good candidates for IUDs. You can see in black are the list of contraindications. They're not very common. There's not many people that come in for IUD insertion that have endometrial or cervical cancer or are immediately post-septic abortion. Certainly unexplained bleeding should be investigated before an IUD is inserted. But the one indication or contraindication to IUD insertion is mucopurulent cervicitis, where you actually see mucopus at the cervical os. And that is a contraindication to insertion. You should screen for that and then consider having the patient come back for insertion. So we should dispel the myths about IUDs. They do not cause pelvic infection. They are not abortifacients, and we're probably going to hear more of that in the months and years to come. They do not decrease the likelihood of future pregnancies. They do not cause ectopic pregnancies. IUDs actually reduce the risk of ectopic because they reduce the risk of all pregnancies. They do not cause cancer. In fact, we're working on a project now looking at the relationship between IUDs and all gynecologic malignancies. There's very good data that all IUDs prevent endometrial cancer, but there's also some data that IUDs may prevent cervical or even ovarian cancer. So there are non-contraceptive benefits to intrauterine contraception. And you can see here, protection against endometrial cancer is not specific to hormonal IUDs. Also, the copper IUD is protective. And in terms of the hormonal IUD at the bottom, prevention of endometrial cancer, an alternative to hysterectomy for women with abnormal bleeding, and treatment of heavy bleeding and dysmenorrhea. IUDs are appropriate for properly selected adolescents. Adolescents are at high risk for STDs, so we also have to think about dual methods, condoms for STD prevention, and a highly effective method for pregnancy prevention. Shifting gears to the implant, and you can see the CHOICE project focused on long-acting methods, and you'll see that is one of the shifts between the CHOICE project and our new Path for You project, is we have a little less of a focus on long-acting methods in our new project, and I'll explain that later. But the implant, the etonogestrel implant, is a single progestin implant. You're familiar with it. You may be aware it's FDA approved for 3 years, but actually Planned Parenthood, now you can use it for 5 years at Planned Parenthoods. And I think the indication, the length of use will actually probably go up even longer than 5 years. We have some data that we still have to publish that is looking at 6 years of use of the implant, and it seems to be highly effective, and the hormone levels are still reasonable in terms of pregnancy prevention. And you know, it primarily works by inhibiting ovulation, more so than the IUD does. Very effective at stopping ovulation. The secondary mechanism for the implant is to increase the viscosity of the cervical mucus. Highly effective, probably one of the most effective methods of contraception we have, with a failure rate far below 1%. Very few pregnancies in the original clinical trials of 20,000 cycles. The main concern with the implant, as you know, is bleeding irregularities. We've actually done a recent study, a resident research project study, looking at why women discontinue the implant. And yes, it confirms bleeding irregularities, but there are some other reasons that women are reporting they discontinue the implant. One is mood changes. I'm not convinced that that actually is related to the implant versus many other things going on in society at the same time, but it's possible. Some women remove it for weight gain, and there's other reasons that women do remove the implant. Any questions about long-acting methods before I tell you a little bit of the story of the CHOICE project and then talk about Path for You? So the CHOICE project was, as a researcher, sometimes it's better to be lucky than good, and this one fell on my lap, and I'm very happy it did. I received a call from a large anonymous foundation that asked me, I was in St. Louis at the time at WashU, if we would remove all financial barriers to contraceptive methods. They would provide resources to do a contraceptive project, and I can design it any way I want. And first, I designed a multi-center study looking over many sites in the United States, but they said, we'd like you to limit it to your region. I wasn't exactly sure why, but I'm sort of glad they did at that point. And they wanted us to remove barriers to long-acting methods. They seemed to believe that at that time, that there were many women who were not even being exposed to long-acting methods, not even being told about the implant or the IUD. So our goal was to remove that barrier. All women would learn about the long-acting methods and other FDA-approved methods. And we wanted to provide these methods at no cost to see if we could make an impact, not only on continuing methods, continuing the use and satisfaction of the methods, but population outcomes like teen pregnancies. So we proposed to recruit 10,000 women over 4 years, remove cost barriers, and ask patients to choose a method they want. And I'll talk to you about the inclusion criteria, but we wanted them to choose a new method. Why a new method? We didn't want to look at satisfaction and continuation and compare a new implant user with a woman who's been using pills for 3 years and she's happy, that wouldn't be a fair comparison. So we wanted women to try a new method. And we would assess their continuation and satisfaction and look at some of the population outcomes. That's a contraceptive cohort study or prospective cohort study. These were the LARC methods that we were offering at the time, just a single type of hormonal IUD, the Mirena, or now Liletta also as an option, copper IUD, and the subdermal implant. So at first, for the IRB, we had approval to recruit from 18 years of age to 45. We had parents coming in asking us to please get their young teens on contraception, which was actually very welcome. And we've reduced the inclusion criteria to 14 years. They had to have primary residency in St. Louis City or County, sexually active with a male partner or soon to be, not desiring pregnancy for 12 months, and desiring reversible contraception. And as I mentioned before, willing to try a new method so we can compare continuation and satisfaction rates. We actually didn't hit 10,000, about a little over 9,200 patients enrolled. It is probably the only research study I've done, and I've done studies for about 30 years, where we actually recruited on time. This actually hardly ever happens in clinical research, that you actually have patients come in and meet your goals of recruiting almost as many patients as you'd hope to, but in a very reasonable time point. And I think part of that strategy was we went to 2 abortion clinics in our area, 8 community clinics, and we had a university site where we could see patients removed from other clinical sites just for the Contraceptive Choice Project. Word of mouth referrals were incredibly important. Patients told their friends, they told 20 friends, and friends were coming in, families were coming in. Had one mom bring in 3 of her daughters at the same time. So here's a little more of the details. One of the things we did in the Choice Project, which we do not do in Path4U, is we did tiered counseling, starting with the most effective methods first. Now, I will say I had a lot of pushback once I presented these results from my colleagues on the West Coast who felt that we were coercive by doing this. I would say I'm not sure I fully agree with my colleagues that if I had a disorder or I wanted to prevent a problem like an unintended pregnancy, I'd first like to know what methods are most effective. And in fact, when we did surveys of women, women told us effectiveness. Most women said effectiveness was the most important attribute of a contraceptive method. However, we're getting away from tiered counseling in our new project to offer all methods and allow patients to choose based on their lifestyle and what's most important to them. These were the methods we offered. You could see we did, after enrollment, we did screening, STI screens, by sending them an STI test in the mail and leaving it up to them if they'd want to be tested. And then we did telephone surveys. We did not require they come in unless they had a problem and wanted to be seen. And these are pretty excellent follow-up rates, 94, 87, and 81% at 1, 2, and 3 years. This took a very large team and a lot of money. And I don't have the same amount of money in Indiana when we are doing our new project, so we're trying to do it a little more streamlined. Here are some of the baseline characteristics. You can see that over 2,000 women were under the age of 21, so a lot of teens. You can also see the city of St. Louis is about 50% African-American, and you can see we had roughly that in the Choice Project. It's also a fairly high-risk cohort. About 40% had trouble meeting basic financial needs, and about 40% were uninsured. Now, this is higher than national averages, so I would say while our cohort may be very motivated, they've told us they want to avoid pregnancy, they're also a very high-risk group. Probably the most telling statistic is looking at unintended pregnancy. Over 60% of our patients had a previous unintended pregnancy. This is, of course, because we also recruited at abortion facilities. So this is a very high rate. So these women are at high risk for STDs and for unintended pregnancy. What threw our budget off was we never anticipated that 75% of the women would choose long-acting methods. That when they are presented with the long-acting methods first, and then are presented with all contraceptive options, and we paid for everything from the implant to diaphragm and diaphragm gel. How many residents put in fit of the, no, right. I got called to fit the diaphragm because none of my colleagues knew how to do that. So anyway, so we provided everything for patients, yet they chose these methods. And I think because they're highly effective, and I think when you're given something for free, sometimes if you know something costs a lot more, there's an assumption, this might be better. I'd like that one. Or it can last 3, 5, or 8 years. So you can see the mix of methods, different than the US current method mix. Interesting, in young adolescents, there's a shift in method mix, in LARC method mix, as we look at young teens compared to older teens. Young teens, of course, and the residents and others have seen this, they prefer the implant. Avoid the pelvic exam if they can. Once they get to about 18 and older, they're more friendly to the IUD. So we see a shift in method mix in adolescence. So I'll touch on some of the short-term and some of the long-term outcomes of the CHOICE project. This, I'm proud to say, was a resident research project. This was not a goal of the CHOICE project, was to evaluate the effectiveness of long-acting methods. We wanted to give out methods and look at, are people happy with them? Did they continue their method? And this senior resident, Brooke Winter, who's now out on the West Coast, she's a minimally invasive gynecologic surgeon, came to me and saying, my project is falling apart. Is there any project I can work on with you? And I said, let's just take a look and see what our unintended pregnancy rate is within the CHOICE project. And when we compared the results of long-acting methods to other methods, we found a remarkable finding that I thought might be worthy of submitting to the New England Journal. And what we found was there was a 20-fold difference in effectiveness. We knew that IUDs and implants are better than pills in terms of effectiveness, but I don't know of another cohort study that actually compared within a population. What's the relative effectiveness of a long-acting method compared to pills, patch, and ring? And it was a 20-fold difference. That number, that's a hazard ratio, which is like a relative risk or an odds ratio. That's more than a 20-fold difference. There's not many large differences like that in medicine. Smoking and lung cancer, there's a 20 to 30-fold difference, but not many effect sizes are that big. So the New England Journal liked this, and we liked the New England Journal, so it was published. So a little bit about our continuation rates. You can see here that the long-acting methods, not surprisingly, had much higher continuation rates than the short-acting methods or the non-LARC methods. As I said before, Depo is a great method if you come back, but when 50% are not continuing it at 12 months, it's not going to be very effective. So very high rates of continuation and not a big difference at 12 or 24 months between the different LARC methods. Here's satisfaction, and you can see these results mirror the continuation rates. Of course, if you're not satisfied with your method, you're more likely to discontinue. But close to 80% were very satisfied with their LARC method, but much lower numbers for the non-LARC methods. And that's a pretty big difference also. Now, just to touch on one of the most specific population outcomes of the CHOICE project was teen pregnancy. Gina Sakura was the project director. She was a terrific find as an epidemiologist and person to lead this large group. And we compared the CHOICE teen pregnancy rates with the US national rates. And you can see the data is now fairly old, but a pretty remarkable difference. 60% reduction in pregnancy among sexually active teens, 60% reduction in births and abortions with the CHOICE project compared to US population. Now, again, we may be comparing apples and oranges a little bit here because the CHOICE project motivated people coming in with a specific desire to avoid pregnancy. The US population is more of a mixed bag, but I would say the US population has a lot of lower risk women in that cohort with fewer previous unintended pregnancies and much more homogeneous than the CHOICE project. So I still believe our results were pretty remarkable. But I think the most remarkable result was how we could actually remove a health disparity. In green, you can see the US rates of pregnancy rates in teens. And you can see there's not only a fairly high rate of teen pregnancy, but also a big disparity between Black and white. In the blue is the Choice Project results. Not only did we markedly reduce unintended pregnancy, teen pregnancy, but you can see we almost wiped out the difference between white and Black, a health disparity. And I think that's incredibly important. And what it means is if you educate your cohort, educate the population, make it easy access to contraception, you can remove this health disparity. And I think with what's going on today with our government and rules about Roe, that we're going to see increasing health disparities. And I would say access to contraception, and I would love to present this to any state government to say access to contraception is key if we're going to try and get a handle on infant and maternal mortality and the health disparities that are associated. So the residents got most of these points here. What are the three key ingredients? Education, access, and in the Choice Project, we were willing to provide any method that day. We were set up to put in their IUD that day, their implant that day. How many times do women go to their OBGYN and they schedule a follow-up appointment, or we want you to go home and think about it, or they don't even present that method? So access is key. Affordable contraception. So the ability to have, and this was part of the Affordable Care Act. The Choice Project was before Obamacare and the Affordable Care Act. We removed cost barriers and made it affordable to everyone. Questions about choice? So 10 years I was in St. Louis, had a great time during those 10 years. I was then asked to look at a position in Indiana, and I spoke to Laura Rice, who advised me between Indiana and another program, and I went to Indiana, and very happy I did. And now what we're trying to do is do a statewide program of contraception access to reduce infant and maternal mortality. Now, anybody know what an ecological study is? It's kind of a tough methodologic term, but an ecological study is when you do something in a population and you look at the outcome in a population, not necessarily a cohort, but an entire population, and you attribute what you did to the outcome. So we're going to try and make contraceptive accessible throughout the state of Indiana and hope that infant and maternal mortality will go down. But now we have something else going on at the same time, which is reducing women's ability to control their reproduction. And now this blows our project out of the water, in my opinion, in a sense that our project may actually reduce infant and maternal mortality, but I think the opposite is going to happen with what's happening with our government and state governments in Indiana and possibly Wisconsin too. So we are sort of a poster child for infant and maternal mortality in Indiana. This is not very good, 46th in the US in maternal mortality, 42nd in infant mortality. So we have lots of room for improvement. And in epidemiologic studies, you want to start a study when you're really bad, because there's always an opportunity to get better. So we have that in Indiana. Unfortunately, I don't think the timing is right. So what are we doing in Path for You? Path for You stands for pregnancy at a time that is happy and healthy for you. We hope to educate people and clinicians, be a trusted source of information, empower people to make informed reproductive health decisions, foster a mutual trust between clinicians and patients, respect patient autonomy, avoid coercion, which is something the Choice Project was, I think, wrongfully accused of, promote health equity and advocate for vulnerable people, and increase access to all contraceptive methods. We take a reproductive justice framework, the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. So reproductive justice is a different sort of theoretical approach than what we did in Choice. Our goals in Choice would really to present LARC methods, which we felt were underutilized. Different goals in Path for You, where we want to first find out what's important to the patient. If they want to have children, we will facilitate getting them prenatal vitamins or whatever to have a healthy pregnancy. But if they don't, then we provide all methods, again, with a different framework than we did in Choice. We'll provide universal screening for pregnancy preferences and attitudes, comprehensive contraceptive and reproductive health counseling, And similar to choice, same-day contraceptive methods at no or low cost. Our budget is much more limited than choice, so we're going to see how long our project can go on before we exhaust our resources. We are using a website that we developed, and everything starts at our website, path4u.org, and I encourage you, if you're curious, to explore this. And this website helps navigate a patient's choices in getting in for care. We start by finding out what's important to the patient. We then discuss all birth control options for women who want to avoid pregnancy. We help create a path to those options, provide free contraception to them that day, if at all possible, and have access to us and our team 24/7 as best we can to provide information and counseling. We do this with a Birth Control Explorer, which is actually a decision aid that helps patients choose the best birth control method for them based on answering some basic questions. We start with pregnancy intention screening and then provide this information, comprehensive information about all birth control options. We use a PATH framework. This PATH framework has been used in many other studies, asking questions about pregnancy, parenthood, attitude, timing, how important pregnancy prevention is to the patient. To some patients, it's very important. To some, whatever happens, happens. We see a lot of ambivalence sometimes when we counsel patients about contraception. Questions like, do you think you might want to have more children at some point? When do you, or any children, when do you think that might be? How important is it for you to prevent pregnancy until then? So we also use a tool called My Path Tool, which helps the patient navigate their journey to contraception. Everything is done either online on a computer or with an iPad. And you can see we ask questions about how satisfied they are with their current method, help them figure out if there's a better method for them. If you remember in choice, we sort of mandated that patients choose a new method. Not in this project. They can stay with the method they want. We can just help with their access to the method. The Birth Control Explorer is actually a decision aid, as I told you, which helps patients navigate their contraceptive options based on what's most important to them. What we do is we provide telehealth, which is new. We didn't do that in choice. And of course, you know, from the pandemic, this is something we learned can be very effective. And we provide in-person care also for patients who request it, or if they want a LARC method and need an insertion. Same-day access to free birth control will include, for short-acting methods, CVS vouchers. We're partnering with a pharmacy to help get patients the methods they need, or we can do mail order for patients who want methods delivered to them. For LARC methods, we provide access to same-day insertion through partnering with organizations and provide these devices at no cost to the patient. The other thing that's different about the Path4U study is that we're engaging our community. We have two advisory boards, a provider advisory board and a community advisory board. And these boards help us shape our project, help us with key decisions as we go along and grow our project. We also are using digital media, much more, greater access to website development, easy access to care through digital means. And we are developing a marketing strategy. Our first marketing firm, I think, failed miserably. We fired them. We're moved on to a new firm because we need to be able to reach the patients. We want to access our project to get their free contraception. One thing we learned in choice is that low tech sometimes can work better than high tech. In choice, we just had posters and signs on the metro in St. Louis and bus stops. And we did everything digitally to start. And we were doing very poorly at the beginning. And finally, we put up some posters and bus ads, and now our numbers are really picking up in terms of recruitment. I don't have results for this study yet, but we are working on growing the number of people enrolled. We're up to about 150 so far, hope to grow to many thousand. Social media advertisements are also an important part of our link to patients, and we try and be friendly to a diverse community and to vulnerable patients by providing social media posts and giving messages that are appropriate for the group that need contraception the most, that need access to methods the most. So in summary, our goals for the Path for You project are to see if we can reduce infant and maternal mortality. As I said, I'm a little less optimistic about these population outcomes. I still think it's an important implementation project to be able to show that we can improve education and improve access, even in a very conservative region of the country. We want to increase access to contraception as people plan their pregnancies so they can plan for healthy pregnancies and avoid unintended pregnancies. And our focus on the reproductive justice framework is new for Path for You compared to choice, but I think it's the right thing to do at this time, especially with what's going on in our current events. Just a reminder that family planning actually saves healthcare dollars. This was a article we wrote in the New England Journal a few years ago where we tried to quantify the savings. Every dollar invested in family planning saves several dollars in terms of long-term cost to the health system, greater savings for long-acting methods because those are actually the most cost-effective methods. And I'll stop there, and I'm happy to take any questions or comments. Thank you very much. Yes.
There's a microphone coming.
Oh, that's a microphone.
Thank you so much for this great talk. In our resident clinic, we have already recently seen quite a large spike in patients coming seeking permanent sterilization in the setting. And I assume it's probably because of things recently going on with Roe v. Wade. I'm curious with Path for You, do you guys have a protocol or how are you triaging people who may indicate that they're interested in sterilization rather than other contraceptive methods?
So the question for those that couldn't hear was, how are we handling sterilization requests? And that's really been an interesting, you sort of hit the nail on the head in terms of controversy among our team. Choice Project, given that we had an anonymous donor and pretty much a blank check, cost over $18 million for a region. We're trying to do a statewide project for $2 million. We continue to fundraise, but you can see this is incredible difference. So I and the entire project team, and it's not just me, I have a great team that's working on the Path for You project. We're trying to be really good stewards of that money. And the question is, in terms of cost effectiveness, can we offer sterilization? And it's really controversial because of course the reproductive justice framework would say, absolutely. If a patient wants sterilization, you should provide it. From a behavioral or just an economic point of view, we have really focused on reversible methods. Mm-hmm. And that's a hard one for me, honestly. And it's hard because I feel like when you have IUDs and implants, and we're actually getting them for free from the pharmaceutical companies, and that again may be a form of coercion, these methods are not only as effective as sterilization, but reversible. So we're still wrestling with that. And if we could get a price point that we could get vasectomy at a reasonable price. Now, sterilization in the United States for women is incredibly costly, you know? And so we're still wrestling with that question. I don't have a good solution yet. Good question. In the back.
Thank you very much for sharing your work with us. I'm curious, the slide you presented where you demonstrated that in the Choice Project, you were able to basically eradicate that disparity between white and Black teenagers, I think it was. Are the US data similar to the data in that region? Like, are the Black-white disparities in that region without the Choice Project similar? Or are you in a situation where because of the 50-50 white Black population, you're doing better with disparities already?
So the question is, would we have comparative data, I think, in our region compared to the Choice Project? And I'm not aware that we haven't been able to find that. First of all, I've done some work looking at state data on unintended pregnancy. It's not easy. And for that reason, many people use the proxy of teenage pregnancy because we know that 80% of those roughly are unintended pregnancies. But unintended pregnancies the way I'm presenting it, it's like it's black or white, right? It's either unintended or it's not. That's not the case. There's a big gray zone of somewhat intended. I wasn't really trying to avoid. So you can't really label it that clearly. And state data doesn't provide, I think, the granularity to make that comparison. I would guess, and again, just an educated guess, that the health disparities in St. Louis between black and white are still quite great outside of the Choice Project. And I would bet, now the Choice Project's over, again, probably access has increased in the St. Louis region, but I would bet when we go back to issues of cost and reduced access and not universal education, we would still see great disparities even in that region. Again, an educated guess.
Two questions for you. The first one, in your study that was looking at the effectiveness of LARCs in that, most impressive resident research project ever article. I assume that was for people who continued that method. Have you guys considered doing like an intention to treat analysis for that kind of information? And then the second question, in the Path for You study, maybe you mentioned this when you started recruiting and how many people you have at this point, but I'm curious if you think you're going to have enough data before these policy changes come into effect that you could compare before and after.
Yeah, the second question is easier to answer because the answer is no. The recruitment rate for Path for You so far has been incredibly disappointing for me because the Choice Project, we had 50 patients every week coming in for Choice. I had never had recruitment like that in my life. My project director begged me not to advertise anymore because we couldn't handle the volume. So Path for You has been a struggle. Now, part of that is our project was approved at the end of 2019. What happened in 2020? Lockdown pretty much, right? So 2020, 2021 were pretty much a wash. We did telehealth visits occasionally, but many were not coming in. So the other question was about intention to treat analysis. And that's a great question because really in a randomized trial, when you allocate people to two different things, the right way to do the randomized trial is to look at the outcomes, whether they continue using that method or not. That's an intention to treat analysis. There's a very smart guy in family planning named Matt Reeves. Some of you may have heard of him. He trained in Pittsburgh and now is in practice in Washington, DC. And he approached me and said, hey, can I have your data and do an intention to treat analysis? And he did. And it was published. I wish I could provide the citation. I should be able to actually, if you Google Reeves Choice Project, you'll probably find it. And the results were not very different. They are different. It's a sort of a regression to the mean or to less big differences, but we still saw remarkable effects. And it's because in intention to treat, the people who discontinued their method are the ones that cloud the picture, right? They started on pills and then they stopped and they get pregnant. People with long-acting methods have a much higher continuation rate. So we saw a remarkable difference because those people, I don't want to say, were better adherers to their methods. They stayed with it. And by the way, another thing about choice and coercion, we told every patient with a long-acting method that they could come in at any time and have their method removed. Now, I don't think as a clinician, we would do it without at least asking questions like, why are you getting your method removed? And is there something we can do that can help with your irregular bleeding? But if they wanted their method out, we took it out. There was no coercion to require that they keep it in any length of time. So hope I answered your question.
We have a question online.
Okay.
I think I can see it here. Let's see if I'm smart enough. Oh, yeah, go ahead and unmute yourself and then we'll get to Katie's question online. Can you unmute?
Hello, can you hear me?
You
Yes.
can.
Oh, one question I had was, and thank you for that great summary of LARCs, do you think that birth control will be the next attack that we'll see in terms on an actual birth control in certain states?
The short answer is yes, I do. And I think this is where we, as advocates for women, should maintain a strong stance. I heard an NPR interview with a family planning expert who inferred that IUDs prevent implantation as one of the methods that they work, one mechanism of action. And I thought that was not a fully accurate statement. We don't know that for a fact. We know that copper actually is toxic to sperm, so may prevent fertilization. So that is not an abortifacient. And I believe the primary mechanism for the hormonal IUDs is not to prevent implantation, but more to prevent ovulation and prevent the sperm to reach the egg. So I think we have to be consistent with our policymakers and our state government to say, these are not abortifacients. These don't cause abortions. You're clouding a picture. This is not part of the abortion equation. And this is part of good reproductive health care and prevention. So I do think contraception will come under attack. And I hope voters and everyone that's passionate about women's health will stand together with women to advocate for access to contraception.
Thank you.
The question on the chat, which I believe is from Dr. Sempene, we are working via our DEI committee on optimizing our contraceptive counseling with a framework of reproductive justice, cultural humility, and person-centered care. I really appreciate the thoughtfulness of your new project compared to choice. Are your questions for your study available for us to review to see if we could use them as we consider our optimization project?
So yes, questions for the study. So I would just say, email me any questions you have or any requests you have. We want to disseminate our project far and wide. I don't think that our tools are that we own, the MyPath framework, the birth control counseling option, these are all were freely available. So we're happy to share our resources with any group in an effort to provide better health equity and access to contraception. Happy to do that. Actually, the smartest thing I did was get a great, and this is probably true for a lot of leadership, is surround yourself by great people to work with. And I have actually removed myself as the principal investigator of the project, Path for You, and I have an adolescent pediatrician, Bronson Tucker Edmonds, who's the leader of our diversity and health equity for the entire health system, and a complex family planning fellowship graduate as my trio of leaders for this project. And they are really doing an incredible job. And I'm now sort of the fundraiser. I try and raise money to keep us going and cheer the team on and give pointers where I can in terms of getting us up to a higher level of recruitment.
Other questions from the audience or in the chat or unmute? I have a question. As an oncologist, the main reason I prescribe contraception is actually to BRCA patients to reduce the risk of ovarian cancer. And I tend to use the best epidemiologic data available and prescribe birth control pills. Can you comment on any data you've seen or collected on LARCs and ovarian cancer risk?
Yeah, so birth control pill data is very solid, in terms of ovarian cancer risk. We know that, and there's good data and randomized trials for on that. There's very scant data on IUDs and ovarian cancer. So anybody ever hear of the APEX study? The APEX study is something that's fairly recently published. It's the Association of Perforation and Expulsion with IUD use. So it's looking at risk factors for expulsion and perforation with IUD use. And it is a study of over 320,000 IUD insertions in the United States. We were part of the APEX study in Indiana. I bring this up because this cohort of over 320,000 IUD users is a group that I would like to now look at in terms of those patients who developed ovarian cancer. Now, what am I missing for those budding clinical researchers out there? I'm going to look at the incidence of ovarian cancer in this very large group of IUD users. What am I missing in my project to help answer the question of whether IUDs reduce ovarian cancer? A control group. How would you get that? I'm stretching you a little bit here on Research Day. Well, my proposal is that we contact each one of these, not all 320,000, but we contact the women who are going to be part of a study to look at ovarian cancer risk. And we ask them to refer a friend. What's the advantage of that? When you refer a friend, they typically are in the same socioeconomic category or close and of similar age. So it has some built-in controls. And then we phone their friend and ask them about past contraceptive use. But what we need to do is we need to compare IUD users to a control group. But who's the right control group? What if our control group are all birth control pill users? And the IUD use is no different. What would we conclude? I would conclude that it reduces the risk of ovarian cancer similar to OCPs, okay? But the proper control group is probably someone who has not used a hormonal method or an IUD to actually see that reduced risk. And you can see how complicated this gets because ovarian cancer, while it's a real killer in GYN oncology, it's not that common. And even 320,000 women, you have to think about power and sample size. Will I have enough patients to see a difference? So complicated question, but we're hoping to get at it.
Thank you. Let's thank our fantastic speaker one more time.
Thank you.
Okay, it's my pleasure to move on to the next part of the morning. Our first presenter is Shannon Rush, and Dr. Spencer will be introducing her.
Good morning, all. I'm really happy to introduce Shannon to you as our third-year fellow in GYN oncology. Shannon and I have grown close over these 3 years, and I'm really excited for all the work she's done here as a fellow and moving on after this. Shannon is an Amherst College graduate, then went to the University of Washington for medical school. She also did her OB/GYN residency at the University of Washington, and then we recruited her here to fellowship on a day where her flight was delayed. She came late, had half an interview day, and maybe not surprising to all of you, took only half a day to impress us much more than everyone else who interviewed in a full day. So we were really lucky to recruit her. So she has many stories of resilience. We'll save others for about a month from now. Shannon has enjoyed great success. She has 2 first author publications in GYN oncology and the Green Journal as a fellow. She has 4 nationally and regionally invited speaking engagements. She has 3 first author oral research presentations during fellowship and 8 first author posters that she's presented as a fellow. I'm really excited to hear her talk today about a revised Markov model evaluating oophorectomy at the time of hysterectomy for benign indication, age 65 years, revisited.
Thank you for that warm welcome and good morning to you all. Today I will be presenting my work entitled A Revised Markov Model Evaluating Oophorectomy at the Time of Benign Hysterectomy, age 65 revisited. Perfect. Hysterectomy for women in the United States is a common procedure, albeit less so than decades past. Still, there are over 300,000 hysterectomies completed per year in the United States. And by 2018, 31.8% of women over the age of 50 had undergone hysterectomy. Also of import is the fact that hysterectomy, that while it's decreasing in reproductive aged women, it is increasing women over the age of 55. The question to remove or retain ovaries at the time of a benign hysterectomy is one that is very commonly puzzled. Why even consider removing the ovaries at the time of a benign hysterectomy? I wouldn't be a good gynecologic oncologist if I didn't care about decreasing the incidence of ovarian cancer. This group of cancers, in the majority of instances, are diagnosed at an advanced stage when curing patients becomes harder to do, although Dr. Hartenbach seems to do it all the time. We all know there is no effective screening. We figured that out in the BRCA1, BRCA2 mutation carrier population. Further, at diagnosis, as much as 14 and even as high as 17% of patients will have had a prior hysterectomy. We thus could probably make a real difference in the incidence of ovarian cancer if we opportunistically performed BSO with benign hysterectomy. Of course, ovarian cancer risk must be balanced with the risks of removing ovaries. Depending on the age and menopausal status at which one undergoes opportunistic oophorectomy, one must consider the increased mortality risk from cardiovascular disease, especially for premenopausal women. There are other risks and benefits of BSO in terms of other cancers, strokes, and risks of reoperation. Morbidity of premenopausal BSO in terms of hip fracture risk, dementia, anxiety, depression, Parkinson's disease also need to be addressed. Further, depending again on age, we have to consider the risks and benefits of utilizing hormone therapy. This topic got more clarity in 2005 when the original Markov model was created and published to help determine the best time for oophorectomy at benign hysterectomy. The model compared ovarian conservation to oophorectomy at benign hysterectomy at various ages, with varying degrees of death by causes including cardiovascular disease, stroke, ovarian and breast cancer, and hip fracture, to come up with a portion alive to age 80 based on the oophorectomy choice. That model ultimately argued for ovarian conservation at least to the age of 65 to mitigate the mortality risk. That recommendation was in large part driven by the risk of cardiovascular death when oophorectomy was performed before 65 and without estrogen replacement therapy. In fact, that risk was the largest driver of their recommendation for waiting to age 65. This is highlighted here where the blue box demonstrates quite eloquently the large difference in cardiovascular mortality risk in those undergoing oophorectomy without estrogen replacement therapy. A bit about Markov models. They are statistical tools that help predict risks of outcome based on decisions made. They assume that over time, individuals in a population transition through various discrete Markov states with transition probabilities that depend on the current time and state, but not necessarily on any previous states. Basically, they allow us to simulate populations of people that might transition from one state of health to a different one, depending on established risks or choices of intervention. It allows the modeling of individual decisions, for instance, about ovarian conservation versus oophorectomy, to predict mortality outcomes based on age-related and population-based risks of disease. It is important to understand, though, that it is a model, and thus only as good as the research, data, and studies utilized to create it. That said, sometimes a guideline is clear-cut and catching as the one outlined in the 2005 paper takes hold. Many people to this day had considered 65 as the earliest at which we can safely remove ovaries at the time of benign hysterectomy. This particular paper has been cited in many an oral board's exam to justify surgical choices. While it was published at a time when far too many prophylactic BSOs were performed in average risk premenopausal women, reversing that scary trend, it also disallowed further discussion about whether age 65 made any physiologic sense. A 2011 paper demonstrated a trend of decreasing oophorectomy at the time of benign hysterectomy in the year after the model was published. Note in their paper, there is no age group of women where oophorectomy is more common than ovarian conservation at the time of hysterectomy, even in women 65 and older. The only other time they noted a significant decrease in oophorectomy over the course of a year was after the publication of the Women's Health Initiative study, evaluating safety of combined hormonal replacement. Since that 2005 paper, however, multiple intervening population-based studies have been published that argue against waiting to age 65. I want to be clear that I'm not arguing here for consideration of premenopausal opportunistic BSO. There's plenty of support that doing so unduly increases risks of mortality and morbidity. But many of the same studies that would argue against premenopausal BSO do not find such increased risks in menopausal or 50 and older patients. Despite these newer studies and the difference that the newer studies are population-based and not models, it has been taken as irrefutable to delay oophorectomy at benign hysterectomy to age 65. The support for this age continues to be the 2005 Markov model. The objectives of our study were thus to revisit the original model, perform a literature review to capture the intervening data, and revise and update the model with the information we'd gleaned from the literature review. To create the model, we did a close reading of the methods to ensure we got the same results as previously published. We assessed the original studies that were used to establish the risks of the disease under study. We then coded a replication of the model, seeking to reproduce the same results so we knew exactly what steps were taken to get the answers they did in the original. We next performed a literature review with key terms and then manually reviewed all the work cited to ensure we captured all the relevant data. We sought studies to define the reference group's risk of disease, and the referent group being no surgery at all. We also evaluated those groups undergoing hysterectomy, both alone or concurrent with BSO. We further looked at the effects of estrogen replacement on those undergoing BSO before age 50. We specifically targeted those papers published after 2005 and through 2019, and we focused largely on European and US-based populations. Finally, we recreated the model with updated studies, as well as updated CDC vital statistics to capture current mortality risks from the diseases of interest. Here is a schematic of our model. We modeled individuals as starting out with at least one ovary prior to hysterectomy with a uterus in place. The individuals were then modeled as undergoing hysterectomy alone or hysterectomy with oophorectomy from ages 45 to 55 in 1 and 5 year increments. For those under age 50, we modeled those who underwent oophorectomy as either utilizing or not utilizing postoperative estrogen replacement therapy, at least to the age of 50. We actually dropped hip fracture as a cause of death, given that in the original model, it was a calculated rather than an experimentally derived mortality risk. We then simulated a population of 10,000 women whose paths were influenced by the age of surgery and postoperative estrogen use to model what proportion of those patients would be alive to age 80 or would succumb to cardiovascular disease, stroke, or cancers of the breast, ovary, colon, or lung. To account for the hazard ratio uncertainties reported, Bayesian integration was performed, meaning that we varied the hazard ratios for diseases of interest across their confidence intervals. Our first task, as you all remember, was recreating the original model, and we were successful. However, in so doing, we were unable to verify the cardiovascular risk utilized in the original model. The original model quoted in the upper left states that the risk of CHD decreases 6% for each year oophorectomy is delayed after menopause, and the relative risk was adjusted accordingly from ages 55 to 65. The source cited for this calculation is a paper by van der Schouw et al. Entitled Age at Menopause as a Risk Factor for Cardiovascular Mortality, which found that cardiovascular disease decreases by 2% each year. Menopause is delayed, not 6%. Van der Schouw studied menopause for any reason, and women with a hysterectomy were evaluated separately than those who underwent oophorectomy. Further, Van der Schouw never evaluated women undergoing BSO after menopause, so it would be impossible to have found an increased risk of cardiovascular disease with BSO after menopause, let alone the 6% increased risk per year that was utilized in the original model. Further, only 7% of their patient population underwent menopause at or after age 55, so commenting on age 65 was not feasible. This falsely elevated the mortality by CHD that was associated with BSO without use of estrogen, and hence largely explained the recommendation drawn from the original model to delay concurrent BSO to age 65. Our next task was a literature review. We found a number of prospective and retrospective large population-based studies comparing hysterectomy versus no surgery and hysterectomy with or without oophorectomy. This first table demonstrates the most pertinent studies whose findings were incorporated into our Markov model. They are the studies that look at women who underwent surgery at various ages and their risks of disease based on concurrent oophorectomy and postoperative estrogen. The Jacobi study is based off of the WHI observational arm. The Rivera study is a product of the Mayo Clinic study on oophorectomy and aging, while the 2013 Parker paper is a nurses' health study of those women who had previously undergone hysterectomy. Chan's study was a Kaiser Permanente study. This next table highlights the referent group as compared to hysterectomy. Garak's study was based off of over 53,000 women in the breast cancer and detection and demonstration follow-up study, whereas Laughlin-Tomaso was based off data from the Rochester Epidemiology Project out of Olmsted County. Dixon-Stewart study was completed in a West Australian record linkage study. Here's our primary finding. overall survival to age 80, or proportion alive to age 80. As you can see, if surgery including hysterectomy and bilateral salpingo-oophorectomy was performed before age 50 without estrogen replacement therapy, the proportion alive to age 80 was significantly less than the group of individuals modeled as having hysterectomy alone before age 50. That's 52.8% alive to 80 versus 63.5%. Importantly, however, if surgery was performed after 50, there was no survival benefit noted in avoiding BSO, 66.9% in the VSO population versus 66.4% in the hysterectomy alone population. When estrogen therapy was utilized in those having hysterectomy plus BSO before age 50, there was no difference in survival to age 80. When looking at the cardiovascular disease mortality specifically in the latter column, which was the largest contributed of mortality associated with BSO in the original and our revised model, we found that only in the group with hysterectomy plus BSO before age 50 and without estrogen therapy was there a significant increase in mortality risk. That risk was undoubtedly significant, though, with an absolute risk increase of 10.3% as compared to hysterectomy alone before age 50. Death by cardiovascular disease was similar in those with hysterectomy plus BSO before 50 who received estrogen and those after 50 who either underwent hysterectomy alone or hysterectomy with BSO. Here I also show the other causes of death that we reviewed. Interestingly, both stroke and CHD risks were mitigated by postoperative estrogen in those who underwent hysterectomy plus BSO prior to age 50. And notably too, breast cancer risk was not in fact affected by those who underwent BSO before 50 and utilized estrogen therapy. We finally graphed the survival curves of those modeled as undergoing hysterectomy plus BSO without estrogen replacement therapy versus hysterectomy alone for various diseases and overall, modifying age at surgery from 45 to 55 by 1 year increments. As you can see, if the proportion alive to age 80 diverges at all at the younger ages, they tend to overlap by age 50 and cross in terms of overall survival at age 53. As a sensitivity analysis, we also created the survival curves with just as significant mortality causes, that being death by cardiovascular disease and ovarian cancer. Again, by age 50, we see no difference in mortality when ovaries are removed. Further, this model used stepwise age groups with a step off at age 50, and still without smoothing out over 1 year increments, the survival rate to age 80 is the same when performing oophorectomy at or after the age of 50. Our limitations are those of models in general. They are only as good and pertinent as the data inputted to build them. Further, we focused on this study, on mortality risk alone and did not factor in morbidity concerns. We also did not specifically highlight salpingectomy, and I can talk about that if there are questions. However, I will say that the literature that we reviewed in terms of morbidity was similar in trends as the mortality that we utilize in the model. In conclusion, BSO can safely be performed at the time of a benign hysterectomy in women over the age of 50. BSO before age 50 should be avoided due to the increased cardiovascular mortality risk. If BSO must be performed prior to the age of 50, then estrogen replacement therapy mitigates mortality risk. We found in our model, similar to the original, that cardiovascular risk is the biggest contributor to mortality risk when performing BSO prior to age 50. However, that risk was erroneously increased in the original and supported a false stance that BSO could not be considered before the age of 65. This work will hopefully allow a more informed and updated discussion with patients regarding BSO at time of benign hysterectomy. We can safely say from the data that we have that removing ovaries after age 50 or menopause does not increase cardiovascular mortality risk and decreases risk of ovarian cancer and the reoperation rate. We should counsel against BSO prior to age 50 in those without an ovarian indication, but we should be also empowered as well to provide estrogen replacement to those undergoing BSO prior to age 50, at least until the age of 50. And finally, as previously stated, Markov models are great tools for helping us to guide patients on medical decisions. They must be revised, however, when new population-based data becomes available and as the population-based risks change. We have now revisited age 65 and must move on from this recommendation. And I wanted to thank you all for your time. Thank you so much to Dr. Rose for his help on this project and all of my gyn-oncology mentors, the Department of OBGYN, my co-fellows, and the wonderful residents of this program.
Thank you, Shannon, for wonderful work. To respect time and other presenters, we have time for one question from the audience.
So that's a complicated analysis. The one thing I don't understand about the Markov model, and there's probably many things I don't understand about the Markov model, is, and someone else brought up the point earlier about intention to treat analysis. When a woman makes a decision to be on or not be on estrogen therapy, that decision may not last for long. She may change. Does the Markov model, which seems to sort of label people as estrogen therapy, yes or no, does it account for changes in that decision?
So in this is a yes/no question. So if people under the age of 50 decided to go or underwent a BSO for whatever reason, then the model accounted for a portion of them either undergoing estrogen therapy for up until the age of 50 or not. But the calculations for the risk reduction using estrogen was they were gotten from a large population-based study. So it accounted a little bit for probably standard use. They modeled people as either taking estrogen until 45 or taking estrogen until 50. So it's not perfect.
Igor, are you here? Oh, you're right here. Hi, come on up.
All right. Good morning. I'm delighted to present this morning Janie Jacobson. As you may know, Janie got her medical degree from here at the University of Wisconsin, and from here went to St. Louis University for her residency, and we were lucky to get her back for fellowship. And I am especially delightful to present her today because the work that she'll present today, it's a testimony of how great things can be done despite difficult times. I think particular to Jenny's time on this research were the difficulties of doing basic science and recruiting patients through COVID. And unfortunately, Jenny also endured the unexpected loss of her key collaborator at the lab, which certainly was a multifaceted great difficulty, yet she was able, with the help of Dr. Bird and everybody else at the lab, to pull this research together. And I'm very happy to be able to be here and for her to be able to present it after many doubts if this was ever going to be able to be done. So she'll be presenting a uterine artery endothelium enhances the development of hypertension in preeclampsia via immune-mediated secretion of Th17 cytokines. Please help me welcome.
Good morning, everybody. Thanks for joining us. All right, so preeclampsia is an increasingly common obstetric complication affecting about 8% of pregnancies, and more recent data is showing us possibly up to 15%. There are two predominant theories regarding the underlying pathophysiology and the development of preeclampsia: the vascular development and uteroplacental hypoxia theory, as well as the maternal immune-mediated inflammatory response theory. With regard to the latter, prior studies have shown that hypertensive pregnancies are associated with cytokines such as TNF-alpha from immune cell lineages of the Th1, Th17 kind. So why are we doing this study? More evidence is arising that with the same Th17 mediated immunologic process is also implicated in preeclampsia. We aim to bridge the gap between the concepts of an immune-mediated cause and the vascular development uteroplacental hypoxia origin. Neither can satisfactorily explain both the origin and presentation of the disease process, and there are currently no corresponding reliable biomarkers for use in the clinical setting. So kind of the foundation of this project is came from Adams et al., who showed that in response to TNF-alpha exposure, pregnant sheep uterine artery endothelial cells produce statistically significant amounts of IL-4, IL-7, and IL-12P70 compared to the basal state. This exposure changes the endothelial cell to a Th17 inflammatory cytokine phenotype similar to immune cells and acts as a positive feedback loop promoting inflammation and the development of preeclampsia. They did not, however, find substantial amounts of the expected Th17 pathway products of IL-1 beta, IL-6, or IL-8 on the multiplex assay. Interestingly, their transcriptomic analysis did in fact detect mRNA sequences of these interleukins within the media. The cells appeared to be able to produce the substances, but the interleukins themselves were missing. The initial study using sheep uterine artery endothelial cells relied upon a multiplex assay that was designated to detect human growth factors and cytokines rather than ovine species. We hypothesized that a lack of detection in the cell media may simply be due to species differences in peptide sequences that prevented antibody detection in the multiplex assay. For example, ovine IL-6 peptide is different in length from human IL-6 peptide with only 87.7% amino acid sequence homology. And similarly, ovine IL-8 peptide has only 82.1% amino acid sequence homology to human IL-8. We hypothesized that the inability to detect the substances of IL-1 beta, IL-6, or IL-8 in the media from pregnant sheep uterine artery endothelial cells that are induced via TNF-alpha to the Th17 pathway is actually the result of inability to detect them and not a lack or absence of the interleukin secretion. Further, we hypothesize that these cytokines will be expressed by the uterine artery cells in levels beyond the basal state and can be detected using species-specific antibodies. We also have a second component to the project, which I'll discuss now. Transcriptomics shows how TNF-alpha drives dysfunction by promoting matrix metalloprotease or MMP secretion, and MMP secretion in turn damages the cell monolayer by degrading surface junctional proteins. Normally, these junctional proteins keep endothelial cell monolayers tightly coupled to maintain the barrier between serum and underlying tissues. Junctional proteins also couple endothelial cells close enough together to maintain the CX43 gap junction, which you can see here, that work to synchronize calcium signaling between cells that mediates prolonged nitric oxide production and promotes vasodilation. JAMA and VE-cadherin are junctional adhesion molecules that help hold these endothelial cells together in the monolayer, and these proteins span the membrane and the extracellular domain, then finds another JAM or CAD molecule to bind to. When these junctional proteins are broken down by MMPs, they release shed components that can be detected in the media. Our hypothesis is that initial elevations in TNF-alpha are then amplified by the endothelial cell's own local production of interleukins and leads the cell to secrete MMPs that then break down the vascular endothelium junctional proteins and damage the cell monolayer and shed these proteolyzed components in the media. Specifically, using proteomic analysis, we examined the molecules of JAMA and the shed cleaved product shed JAMA, as well as VE-cadherin and shed VE-cadherin. To test these hypotheses, we repeated the media analysis of the pregnant sheep uterine artery endothelial cells treated with TNF-alpha and used advanced proteomic analysis with ovine reference database and a newly developed ovine multiplex assay. First, we started with cell culture. Pregnant sheep were terminated at 120 days gestation, which is equivalent to the third trimester, and uterine arteries were collected in accordance with institutional animal care and use committees. protocol. The uterine artery endothelial cells were isolated and grown in culture, and treatments were the media alone, TPA, TNF alpha, or negative control VEGF, as well as kinase antagonist PP2 and U0126. And then the dishes were placed on ice and processed. Next, for the transcriptomics analysis, media was removed, cells were snap frozen for RNA extraction, and the analysis was performed at the UW Biotechnology Center. Data was obtained using transcriptomics via DNA microarray using the Affymetrix ovine ST1.1 chip. For proteomics analysis, conditioned media was recovered and centrifuged to pellet cellular debris, and the supernatant was removed and sent for proteomic analysis at UW Biotechnology Center. Peptides were analyzed using protein mass spectrometry instrumentation. Treated cell media was analyzed using the multiplex assay. And essentially the multiplex assay is very similar to ELISA, but it uses magnetic beads rather than plastic plates. And the beads for each analyte are identified with fluorescent dye embedded in the matrix. After incubation and secondary and detection antibodies, the beads were analyzed in the Luminex 200 TM software, a flow cytometry-based system. For statistical analysis, we first did a proteomic analysis, and queries were done through the National Center of Biotechnology Information, RefSec genome records for Ovis Aries. Statistical analysis was performed in Sigma plot version 12.5, and a one-way ANOVA was performed to look at differences in the groups. The proteomic analysis is shown here. It was performed with the media collected from cells after 18 hours of treatment. And there were 1,417 distinct proteins detected from 4 independent replicates. And this proteomics analysis demonstrated significantly increased levels of precursor chemokines, the CCL2, CCL5, CCL20, and the interleukin IL-6. Regarding junctional proteins, the complete membrane spanning region, which is kind of highlighted in green here, it may be hard to see, were never detected in peptide fragments. However, the shed JAM-A and shed VE cadherin, the shed products, were detected on our proteomic analysis. Using the new multiplex assay, which is the ovine rather than human cytokine chemokine panel with species-specific antibodies, we detected IL-1 beta, IL-6, and IL-8, as well as CXCL10 in the media. And this is our dose response for interleukin secretion. These are our plots here. IL-6 was secreted in the basal state, but showed a clear increase in response to TNF alpha that was significant. IL-8 was not secreted in the basal state, but dramatically and selectively increased by exposure to TNF alpha. And IL-1 beta was barely detectable and not consistently increased by any treatment. Additionally, our chemokine CXCL10 was also significantly elevated above basal levels. So essentially, we are proving our model here, which is external TNF alpha exposure from the placenta or immune cells, presumably initiates a vascular endothelial shift to a Th17 state. Previously discovered, so our endothelial shift under the exposure of TNF alpha, and previously discovered IL-12P70, IL-4, and IL-7 will influence the development of Th17 lineage in immune cells. We then determined that both external TNF alpha exposures then added to local IL-6 and IL-8 secretion from endothelial cells, but not the secretion of IL-1 beta or other detrimental substances such as interferon gamma. These appear to be solely under the regulation of non-endothelial cells. We have shown that initial elevations in TNF alpha leads to local secretion of MMPs and the breakdown of junctional proteins and the shedding of their proteolyzed components in the media. We found that secretion of shed junctional proteins was very specific and quantitatively was most represented by shed JAM-A and shed VE cadherin. An increase in shed JAMA and VE cadherin in response to TNF alpha was also significant, and this suggests that the MMPs do autolyze or destroy their own cells' junctional proteins. The implication is that not only is there a loss of nitric oxide production from the decoupling of the cells and loss of cell membrane, and with it, the loss of vasodilation, the loss of junctional proteins and the endothelial cell monolayer leads to increased vascular permeability and interstitial edema, both of which are commonly manifested in pregnancies affected by preeclampsia. So the combination of proteomic analysis and ovine multiplex assays have given us much more insight into the role of TNF alpha as a trigger that promotes a feed-forward loop of immune cell recruitment to the uterine artery, and then activation of the endothelial cell to a more inflammatory state. We identified the endothelial immune cell interaction that mediates endothelial monolayer dysfunction via endocrine signaling. We demonstrated that TNF alpha increases MMP secretion and provides a separate non-endocrine proteolytic process involved in the monolayer damage. Our findings suggest that immune stimulated but direct enzyme mediated damage of the endothelium is the basis for edema in preeclampsia. As Dr. Igor alluded to, we had some limitations and challenges during our study. First of all, this study, the obvious limitation is that we're looking at a pregnant ovine model rather than a human model. Our initial intent was to actually look for these interleukins within serum from women diagnosed with severe preeclampsia. But unfortunately, related to some COVID-related limitations, we had trouble with obtaining those samples. So our hope, or my hope, as well as Dr. Bird's, would be for this, is that this is an area of future study that hopefully we can confirm the model that we've helped to outline and actually test this hypothesis in human studies to help further validate it. And just a final special thank you to Dr. Ian Bird, who is my research mentor for this and has been a longstanding active researcher in perinatal research lab. And then just dedicated to Jason Austin, who was tremendous and just an integral part of my thesis project, and a great colleague and friend that will be greatly missed.
Any questions? Any questions from the audience? I'm just curious what other animal models for preeclampsia are commonly used.
That's a really good question. This has been kind of the basis for a lot of the work that's been done, just because sheep are kind of unique in the fact that they're very similar to human pregnancies. They have a really, there's always mouse models that are used, but I think sheep are chosen because they have a very similar uterine placental interface to humans. So it mimics or kind of replicates the human pregnancy state. They're also capable of singleton and twin gestations. And it's easy to, with a shorter gestational period, it's easier to kind of replicate pregnancies and compare to humans.
Thank you. That was a tremendous talk. Any other questions? Congrats.
Thank you.
Okay. Abby Cutler will be introducing our next speaker.
It's my honor to be introducing Dr. Laura Jacques, who will be sharing findings from a qualitative study she led on patient experiences seeking abortion care during the early days of the COVID-19 pandemic. Wisconsinite born and raised, Dr. Jacques attended medical school here at UW before completing her OBGYN residency at the other UW in Seattle. She's been back in Madison since 2017 when she joined our department's ASOG division and currently serves as an assistant professor on the CHS track. Over the last 3 years, she spent a good portion of her time conducting and publishing abortion-related research, specifically medication abortion-related research that's been grant funded with Dr. Jenny Higgins and others at CORE. And in addition to being a prolific researcher and collaborator, Dr. Jacques is also a passionate medical educator, which we know. She runs the OBGYN clerkship, founded and runs UW's mentorship program for third-year medical students interested in pursuing careers in OBGYN, and also frequently serves as a research mentor for our residents. She's also a mother of 3, one of whom is here today, avid if amateur gardener, and is all around a top-rate human whose passion for equitable, accessible, and comprehensive reproductive healthcare knows no bounds. So please welcome Dr. Jacques to the podium.
Thank you very much, Dr. Cutler, for that kind introduction. I'm honored and grateful for the opportunity to be presenting our research. I'm going to be forced to have a baby, COVID-19 abortion experiences on Reddit, on behalf of my co-investigators at CORE, Taryn Valley, Shimin Zhao, Madison Lands, Natalie Rivera, and of course, the great Jenny Higgins. Perfect. How did you do it? You should be able to do it now. Okay. All right. So as we all know, by March 2020, the COVID-19 pandemic dramatically impacted patient care delivery in the United States. And like other areas of healthcare, abortion access and provision were also significantly impacted by the pandemic. But state-specific legislation affected the degree to which care and access changed. At the beginning of the pandemic, 13 states deemed abortion procedures elective, which halted abortion-related care. A 2020 survey by the Bixby Center found that 70 to 90% of clinics in those states had to postpone or cancel abortion services. And that compared to 10 to 20% of clinics in other states. Another survey of abortion providers found that over half had changed clinical protocols because of COVID-19. The changes included increasing gestational age limits, using telemedicine for post-abortion follow-up and other types of abortion visits, and no longer requiring Rh testing for all patients. Research has documented system-level impacts of the pandemic on abortion care delivery, but there's little information about the experience of people who were trying to get an abortion during the early stages of the pandemic. We felt this time period could be used as a case study to better understand the consequences of sudden and dramatic changes in abortion access, something I think we can all see would be useful and important to understand, given the frequency with which restrictive abortion legislation is being passed. The objective of our study was to document the effects of the COVID-19 pandemic restrictions on people seeking abortion. And we did that by analyzing posts on Reddit, which is a popular social media website. And I have to say, when it was one of our grad students who came up with the idea of looking on Reddit, and Dr. Higgins and I were both like, what's Reddit? So I'm gonna give, some of you are gonna be like, I know what Reddit is, but there are people in this room who will be like me, who are like, what's Reddit? So Reddit is a social media platform. It's basically a website that houses user aggregated content, which is dispersed over monitored message boards, which are called subreddits. And these people that use Reddit are called Redditors. So we thought that social media platforms would be a useful source because the data is real time. So you don't get the retrospective bias that you get with survey studies. It's person level data and it's anonymous, which can be helpful when you're doing research on something that's stigmatized like abortion. Additionally, and we thought this was very important, it allows us to capture the voices of the people that are the most vulnerable, people that never even make it through the doors of an abortion clinic. Reddit was chosen because, one, it's very popular with reproductive age people. So 1 in 4 people in the United States that are reproductive age use Reddit, apparently. And at the time that we started this work, it was the 7th most visited website in the United States. So how did we do this? Well, we had some very smart tech savvy people who use Python, which is a code, to web scrape. See, some people, I didn't know what Python was. It's a snake to me. So we took off the first 528 posts on the abortion subreddit after March 20th. And we included all posts from the United States that discuss the pandemic and abortion. And then we used an inductive, qualitative, descriptive approach. So what is that? We determine codes and themes based on what we found in the data. So inductive is meaning that we didn't go into the data with preconceived notions. We saw what was there and then we presented it. We had 3 study team members independently review a subset of those first 528 posts. And then they worked together to reach thematic agreement and create a codebook in Vivo, which is a qualitative software program. The final codebook contained 56 codes. We reached thematic saturation by the end of 169 posts. All researchers independently read the coding reports, generated the suggested themes, and then together, we selected the final 4 clear and coherent themes that I'm going to go through now. The 4 main themes were, not surprisingly, difficulty accessing abortion care. The second theme was quarantine-driven privacy challenges. The third was constrained pregnancy decision-making, and the fourth was compromised abortion experiences. The first theme is the most wide-ranging. This is difficulty accessing abortion care. And so we divided it into 3 sub-themes, which are difficulty accessing in-clinic abortion care, difficulty accessing self-managed abortion care, and financial barriers. So at the beginning of the pandemic, when those states declared abortion non-essential and stopped abortions, Redditors expressed fear that their sometimes already scheduled appointments would be canceled. So one post, for example, reads, "My next appointment was supposed to be tomorrow morning, but they just called and told me to reschedule a week later. I'm terrified this is going to get canceled too, or I'm going to keep getting pushed back. I'm afraid I'm going to be forced to have a baby," which is where we got the title of our talk. So fears of procedure cancellations were so widespread that people who weren't even pregnant were posting about being afraid of what would happen if they were to become pregnant. For example, one poster stated, "Even if I do turn out to be pregnant, I'm so scared of not being able to get a surgical abortion because all of the COVID-19 closures going on. I'm scared and I feel alone." Fears of procedure cancellations turned into reality for many. Sometimes people had their abortions canceled because of abortion bans. Others were canceled due to COVID-19 related clinic staffing shortages. People living in states that banned abortion described the stress and logistical challenges of trying to make abortion appointments and travel arrangements in other states, all while facing COVID-19 travel bans. One particularly poignant posting was a person who described having a medication abortion and then discovering shortly after their state implemented an abortion ban that their pill abortion had failed and they were still pregnant. That person was trying to decide whether to continue this already undesired pregnancy, now high risk due to misoprostol exposure, or make the long trip to a neighboring state to complete the abortion. Many people posted from Texas. One person stated, "Texas doesn't see abortion as essential, so no clinics are taking appointments at this time. It looks like I'll be traveling to New Mexico by myself." The second sub-theme is difficulty with self-managed abortion access. So the pandemic also impacted how people chose to terminate a pregnancy. Self-managed abortion is the practice of terminating a pregnancy outside of the healthcare setting, commonly through the use of mail order medications. Many posters wrote about choosing self-managed abortion. One, because clinic abortion had stopped in their state, so it was something that was easier than traveling to another state. And then 2, some people were afraid to go into a clinic because they didn't want to contract the virus. However, self-managed abortion processes were also impacted by COVID. One of the most common distributors of self-managed abortion is Aid Access, and they work by shipping misoprostol and mifepristone from India. So they ship pills directly to people. This company experienced COVID-related shipping delays of their medications, which led to people receiving their medications late or not at all. One poster stated, "I'm 5 weeks alone. 5 weeks along. Aid Access can't ship my pills until the quarantine in India is over on the 30th of March, at which point they would take still 3 weeks to be delivered to me. I'd be around 11 weeks then. Would the pill still work even though aid access said I had to be below 9 weeks? In response to medication mail delays, aid access pivoted to sending prescriptions for misoprostol alone that patients could fill at their local pharmacies. Not surprisingly, posters describe difficulty filling these prescriptions. For example, hi, we're 5 weeks pregnant. We live in a state with no abortion providers, so we went through the process with aid access. Because of the COVID situation, they were only able to send us a prescription for miso. They emailed it to us, and when we went to the pharmacy with a printed version of the prescription, the pharmacist wouldn't take it unless it's on prescription paper or faxed to them. So the pharmacy called the number on the prescription and no one answered. People looked at other websites that offered self-managed abortion, but they worried about the trustworthiness of these sites due to grammatical errors and misspellings. This person states, I ordered the kit off Abortion RX. There was misspelled words, the sentences weren't grammatically correct, so I was super sketched and weary ordering from them, but I was desperate. In our final domain of the first theme of access-related challenges, the economic fallout from COVID-19 shutdowns exacerbated already existing financial barriers to abortion. Reddit posters described the stress of job loss and furloughs, and it caused anxiety and uncertainty over how they were going to pay for their abortion. One person posted, I'm going to Planned Parenthood on Thursday to have my abortion. I was told on the phone it would be $495 up front. There is absolutely no way I can afford this, especially with the virus cutting my hours so drastically. This abortion is medically necessary due to a heart condition I have. I desperately need advice of what I can do to get help for this. The second theme covered posters describing privacy challenges in obtaining abortion care due to pandemic restrictions. As we probably remember, in the initial stages of the pandemic, people lost their jobs, they were evicted, and a lot of universities shut down housing. So people were rearranging their living arrangements. Kids were going back home to live with parents, and these changes in household makeup, often in close living conditions due to stay-at-home orders, created privacy concerns for people that wanted to have an abortion at home or leave to go get an abortion at a clinic. For example, one poster described the difficulty of leaving the house to have an abortion under the specter of a controlling partner. They stated, he constantly knows where I am. COVID is making my escape to freedom even more difficult. And a young adult post, basically, I'm 6 weeks and 3 days currently. This is my young adult voice. I moved back in with my parents for quarantine, which I would have never done if I knew I was pregnant. And I only have a 1-day window to leave the house from Saturday to Sunday, so I can take my pills of misoprostol. I don't want to be around my family bleeding and in pain. The third theme is constrained abortion decision-making. So this was interesting. Posters stated that they only had an abortion because of the pandemic. And this was for a couple different reasons. One was financial. People were worried that the job loss and furloughs that they are experiencing were putting them in a financial situation that wouldn't allow them to raise a child. Other people just said, the state of the world is so terrible, I cannot and should not bring a child into this. One person said, this is just absolutely bittersweet and overwhelmingly heartbreaking for me. I want this baby, but I know that to be a good mother, I shouldn't bring it into the world that we're in. Some people also said that the pandemic forced them to make pregnancy decisions sooner than they wanted. Redditors described uncertainty about abortion as the right option, but they were so afraid that the choice would be taken away from them due to clinic closures that they had procedures before they felt ready. One person said, I found out on Tuesday and I had my appointment on Thursday. Only reason it had to happen so quickly was because of everything that's happening in the world right now. Abortions are literally being canceled and rescheduled. I personally felt I didn't have time to process or research the way I would have liked because of it. The fourth and final theme is compromised in-clinic, primarily abortion experiences. At the beginning of the pandemic, abortion clinics that could stay open implemented social distancing protocols to prevent the spread of COVID-19. People talked about how uncomfortable they felt with many of these changes. The most common was that they were afraid that they had to go through the abortion procedure alone, not even being able to hold the hand of clinic staff. One person described trying to comfort a young girl while they were both in the waiting room before their procedure. I drove 2 hours to the nearest clinic where they told me due to this pandemic, they weren't allowing anyone besides the patient in the building, no exceptions. There was a 14-year-old girl who wasn't allowed to have her mother by her side for support, and she was a mess. We counted flowers on the wall and talked about her life to distract her mind. So the strengths of this study include its novel data set of real-time anonymous accounts that are unlikely to be captured through other survey methods. The limitations are that posts were short. Sometimes they didn't contain in-depth information or uniform clarity about the geographic location of the poster. And there's no external validity of whether or not what they're posting is true. So the implications. Our work adds what's been missing in the literature about how the pandemic impacted abortion care. Namely, when people lose access to abortion, they feel confused, they're afraid, they're stressed, and they're desperate. Without federal protection for abortion, decisions are going to go to the states, and that's going to create this patchwork quilt of abortion access that people face during the initial stages of the COVID pandemic. Our results highlight the confusion and the emotional distress that the system creates for people. It also creates logistical challenges. How are they going to get to the state that actually will provide abortion care? How are they going to find transportation? How are they going to afford the cost? How are they going to get time off of work, among others? Many people cite self-managed abortion as a possible mitigator to the harms of overturning Roe. We know, based on research by Higgins, that demand for self-managed abortion increases when access to in-clinic abortion decreases. They looked at pre and post-pandemic requests for prescriptions from aid access and found increased requests in the states with the highest number of abortion restrictions. Most notably, a 93% increase in requests for self-managed abortion from Texas. So while self-managed abortion can be safe and effective, a way to terminate a pregnancy, our work highlights that people's experience with self-managed abortion can be variable. People felt uneasy about ordering pills online. And when they did, the differences in state laws about filling prescriptions were confusing to people. Many people had real challenges with shipping delays that led them to get their pills late or not at all. And this is a problem that's unlikely to be solved anytime soon, given the ongoing pandemic and Ukraine crisis. Additionally, we describe how people already at the margins, people living in intimate partner violence situations, people in lower economic brackets, young people, were the most vulnerable to the harms of restricted abortion legislation. Given the specter of the overturn of Roe versus Wade, our results are all the more significant. I want to thank my mother, who watched this presentation multiple times and gave great feedback. Many of the residents here know my mother and her excellent feedback. And I also want to thank my son, Brian, who's here today, got up early to come and watch me speak and also helped me pick out my outfit. That's it. Questions?
Thank you. That was wonderful and scary and moving. Are there any questions from the audience? Dr. Peipert.
A great study, fascinating results and implications. You mentioned at the beginning of your talk the bias of survey studies. Could you comment a little bit about what bias there may be of social media or Reddit studies? You mentioned also that about a quarter of young people, I think you said, use Reddit.
Yes. So obviously, in order to access social media, you need to have technology and a device and access to internet or data that can allow you to be able to interact with that sort of a forum. Additionally, you may have less people who speak other languages. Primary English speakers are the largest user of Reddit, so you're going to be missing certain portions of the population there too. So it's not the answer to get all of the information. It just provides another puzzle piece so that we can try and get a more comprehensive view of how this legislation impacts real people at the time that it's passed.
I have a question. So as you mentioned, this study is all the more salient given what we believe is the impending fall of Roe, and the fact that in 26 states, this will be a reality for most people seeking abortion, including those here in Wisconsin. So if you find yourself in an elevator with a state legislature on his way to vote on impending abortion restriction law here in Wisconsin, what are the takeaways from your study that you would use to make an argument to them?
Yes. I think the big thing is that when people lose access to abortion, it creates incredible confusion. And that confusion sows stress and desperation, and people consider and make choices that they wouldn't otherwise make. So don't do that.
Any other questions before we move on? Thank you, Dr. Jacques.
Thanks.
We have one more speaker. Dr. Ellen Hartenbach will introduce Dr. Jane Seymour this morning.
Good morning, everyone. We are bringing Dr. Jane Seymour live to Wisconsin from Vermont. So let's make sure she's here before I introduce her.
Hi, everyone.
Oh, there you go. She's here. She's live. She can at least hear us.
Can you hear me?
We can hear you, and we're getting your picture up in the corner of your slides. Just
wonderful. Thank you.
Just so that people can see and hear you, and then I'm happy to do an introduction.
You're all set.
Okay, I think we're all set. So we've had a fabulous morning, and I want to introduce our other featured speaker this morning. Dr. Jane Seymour is a postdoctoral fellow in our own CORE program. For those of you that don't know CORE, CORE is our Collaborative for Reproductive Equity, which is a research and advocacy program within the Division of Reproductive and Population Health, which is directed by Dr. Jenny Higgins. And so many of the questions that have come up this morning, I think Dr. Seymour will shed tremendous light on. Dr. Jacques really elaborated the women's voices, and across the trajectory of my career, I always have the women's voices in my head, no matter what kind of reproductive health care that I'm providing. So I just want to give a shout out to Dr. Higgins for recruiting Dr. Seymour into this postdoc position. She has been working in the area of women's reproductive health for over 15 years. She did her undergraduate work at Haverford, where she got a distinction in public health and had a thesis on public health and reproductive triad, a case study in reproductive freedom. She then went on to get her MPH at UPenn, and her thesis there, early literacy and grand mal parity over the reproductive life course. And most recently finished her PhD in epidemiology at Boston University in 2021 with a thesis, Determinants and Effects of Abortion Accessibility in the United States. So she has great expertise in measuring access to abortion services in the country. In her relatively early career, she has received significant grant funding, over 24 published papers in this space, and I am just delighted to turn this microphone over to Dr. Seymour. We really appreciate her being here live and on camera, and we really appreciate her work as a postdoc fellow in our department. So welcome, Dr. Seymour.
Thank you so much for that really kind welcome. I appreciate it. I'm really grateful to be here today to discuss how some of my work in examining abortion access in the United States illustrates how we can measure healthcare access more broadly. So in the next 15 minutes, I want to introduce myself a bit further, talk to you about why I'm here and what motivates this work, discuss how we might best measure healthcare access in the United States, provide an example of this measurement using a study that I conducted on abortion accessibility in the US, and finally discuss ongoing concerns and challenges related to measuring healthcare access. So before I get started, I do want to make a note about the language that I'll use in this presentation. As many of you know, not all people who seek abortion care identify as women. However, to date, much of the abortion literature has focused on the experience of women. So today, when citing past literature that was reported as including women, I'll use that language. Similarly, the census data that we used for these analyses compared the population of included the population of US women, and I'll refer to those data accordingly. But when I refer to people who received abortion care more generally, I'll use the term client. So before I dive into the content, I do want to take a moment to introduce myself a bit more. As was alluded to, I recently completed my doctoral work in epidemiology at the Boston University School of Public Health. And there I studied causal inference and geospatial analysis and applied those methods to questions about sexual and reproductive health. While at BU, I also worked for 5 years at IBIS Reproductive Health. IBIS is a nonprofit research organization focused on work that holds the promise to expand access to sexual and reproductive health worldwide. Since I completed my doctoral training, I left both BU and IBIS to come here to the University of Wisconsin-Madison for a postdoc at CORE. And at CORE, my work similarly focuses on ways to expand reproductive equity. Overall, my goal as a researcher and scholar is to use epidemiologic and geographic information systems, or GIS methods, to answer policy and practice relevant questions to improve reproductive health and well-being. As a result, much of my work focuses on abortion in the United States. As an epidemiologist, this work rests on the understanding that abortion is a determinant of health and well-being. The Turnaway study conducted by researchers at the University of California, San Francisco has found that women who obtain wanted abortion care fare better on measures of psychological, physical, socioeconomic, and social well-being in both the short and long term compared to women who are turned away as a result of being just past a gestational age limit for care. Findings from this study also indicate that subsequent children of women who obtained abortion care had better psychological and developmental outcomes than children of women who did not obtain wanted abortion care. So despite this evidence that access to wanted abortion affects individual and public health, as I'm sure many of you are quite intimately familiar with, there are many, many barriers to abortion in the United States that are well documented in the literature. So what do I mean by access, though? I like to use the model that was introduced in 1981 by Pinchansky and Thomas to understand access. They defined access as an overarching or umbrella term that encompasses the 5 domains that you see here. First, we have availability, which they define as the relationship between the number of providers and facilities to client volume and needs. So are there enough providers and facilities to meet the needs of individuals who desire access to healthcare? Accessibility, I think, is often what people immediately think of when they think of access. So this is the relationship between the location of supply and location of clients. This is often operationalized as distance or drive time to healthcare for a client from, say, their home or work location. Accommodation is the relationship between the location between how services are organized and clients' ability to accommodate to those factors. So this is things like, does the facility offer hours that meet the needs of a client? Are they able to schedule a time for an appointment outside their working hours, for example? All other forms of accommodation include language translation services for clients who might need those services. Affordability is perhaps straightforward to understand. It's the relationship between cost of services and clients' ability to pay for those services. This includes things like what types of insurance does the client have and what forms of insurance does the provider or the facility accept. And finally, there's acceptability, the relationship of client and provider attitudes towards characteristics of the other relative to reality. So are patients willing to, for example, in the OBGYN setting, is having a male provider acceptable to patients? On the other hand, are providers accepting of patients who don't identify as women in the OBGYN setting, for example? So given the importance of abortion to health and continuing barriers to abortion care, measuring access to abortion well is important for public health decision-making. And as a critical component of overall abortion access, accessibility is of interest to researchers. And as I noted previously, often operationalized as distance or drive time to abortion care. And while there's significant literature examining various domains of abortion access, including accessibility, gaps in the literature do remain. So now I want to turn to a study I conducted as an example both of how we measure one domain of access, accessibility, and to provide an example of the type of work that I do and what we're learning about abortion access in the United States. And this study is titled Examining the Potential Impact of Telemedicine for Medication Abortion Programming and Policy Changes on Abortion Accessibility in the United States. So as background, in 2008, Planned Parenthood of the Heartland in Iowa launched a telemedicine for medication abortion, or TMAB, care delivery model. In that model, the client would visit a health center where an abortion provider was not physically present and meet with a remote clinician via video conference. And this model really was implemented in order to overcome Iowa's physician-only medication abortion dispensing law. Evaluations at the time found that compared with in-person medication abortion, TMAB is equally or more safe, effective, and acceptable to both clients and providers. Since 2008, Planned Parenthood has expanded TMAB services to additional states where the service is not banned. However, as of 2018, nearly half of Planned Parenthood health centers did not offer abortion services, and due to the politicization of abortion, TMAB was banned in 19 US states, including Wisconsin, where it continues to be banned to this day. So this study sought to expand on the literature by assessing the potential effect of TMAB ban removal on abortion accessibility among women of reproductive age in the United States. We operationalize this aim by using geographic information systems, again, GIS, to calculate the difference in the proportion of reproductive age US women living within a 30, 60, or 90-minute drive time, respectively, of an abortion providing facility, comparing estimates for two exposure scenarios. And in this case, I'm going to speak specifically about one scenario, TMAB ban removal, and comparing that with estimates for current accessibility. As I'm sure all of you know from your own lived experience, traveling 1 mile may be a very different experience in a large urban center, such as, let's say, Chicago, compared to a rural community like where I grew up in Vermont. So given this, distance is often a misclassification of drive time, which is a more meaningful measure of accessibility for individuals seeking abortion care. So for these studies, we calculated a novel population level measure of abortion accessibility. We operationalize this measure as the proportion of reproductive age women within a given drive time of an abortion providing facility. Given the limited amount of time available today, I'm going to skip over the details of how we constructed this measure, but I'm happy to discuss our data sources, the GIS tools that we used, and any other methodologic details as folks are interested. The important piece to know, which I've already alluded to, is that we consider two scenarios. The current reference scenario, which we called the current scenario, included all abortion providing facilities, as well as Planned Parenthood health centers that offered abortion care in 2018. The exposure scenario, which we'll call the TMAB ban removal scenario, assumed that state level TMAB bans were removed. In other words, in addition to the current level of provision, we assumed that all Planned Parenthood health centers in all states offered TMAB. Our outcome of interest was the difference in estimates of the proportions of women within a 30, 60, and 90-minute drive time of an abortion providing facility calculated for the TMAB ban removal scenario compared with the current scenario. Turning to the results, this map shows in the crosshatch pattern the 19 states with TMAB bans in 2018. On top of that map, you can see the shapes that indicate the portions of the country within 30, 60, and 90 minutes of an abortion providing facility in 2018. The darkest gray shapes represent the 90-minute drive times, while the lightest gray, which are contained within those dark gray areas, represent the 30-minute drive times. Now, here you can see the proportion of reproductive age US women who lived within a given drive time of an abortion providing facility in 2018 in each of the two scenarios, according to our analysis. 65%, 81%, and 89% of women lived within a 30, 60, and 90-minute drive time, respectively, of an abortion providing facility in the current scenario. Whereas in the TMAB scenario, ban removal scenario, 71%, 85%, and 92% lived within those drive times, respectively. To put that into perspective, while these differences may seem small, I want to show you these differences in this chart. So here we show the difference between the TMAB ban removal scenario and the current scenario, the estimates that we showed on the last slide. So the largest percentage point increase in accessibility was 5.66 for the difference between current and TMAB ban removal scenarios at a 30-minute drive time. And while this may seem small, I want to highlight that this means that in this scenario, an estimated 3,530,423 additional reproductive age US women who did not live within a 30-minute drive time of an abortion providing facility would live within that drive time given this policy change. So in this analysis, we found that changes to TMAB programming and policy could expand abortion accessibility in the US. Removing all state TMAB bans and expanding services to all Planned Parenthood health centers that did not offer abortion care in 2018 would result in over 3.5 million additional US women living within 30 minutes of an abortion providing facility. I also want to highlight a few additional results that I didn't present earlier. While these policy and programming changes universally increase abortion accessibility, there was variation in the magnitude of the increase by state. It appears that this variation could be due to a combination of factors, including whether the state had a TMAB ban, current level of abortion provision, and the number of health centers not offering care. Importantly, I also want to highlight that we saw evidence that changes to provision in one state can impact accessibility in another, given that as of right now, people can travel between states in order to access abortion care. Additionally, our findings suggest that TMAB programming or policy changes could have larger benefits for rural communities than urban communities. I also want to highlight now some of our conclusions that are more related to access measurement overall. And these are really some of the limitations of our work. First, as you might imagine, our abortion accessibility measure is likely to be misclassified in some ways. For example, we assume that all women had access to a vehicle, which we know is not true. In particular, low income and people living with poverty are much less likely to have access to a vehicle. So we know that for some people, this measure is misclassified. Furthermore, home location may not be the appropriate measure of accessibility for an individual. It may be that they are more likely to access care from, say, their work location, which may be far from their home. Second, and another kind of overarching concern related to access measurement studies is that we only consider one component of accessibility. And alone, part of what Pinchansky and Thomas theorized is that one component of access alone does not ensure access. So if I live right next door to an abortion providing facility, but it's completely unaffordable because I have no way to pay, then I don't have access. So this study, again, may misclassify access even if accessibility is well classified. So given the growing use of telemedicine, particularly in light of COVID-19 and well-established acceptability of TMAB services, these changes are likely to be highly acceptable abortion provision options and should be considered. Additionally, this study clearly took place prior to our understanding, our deep understanding that Roe is likely to be overturned in the coming months. There are still important implications despite that. So post-Roe, we saw from this study that increases in abortion provision in one state can have impacts in another state. So this will be really important to consider, and site-to-site TMAB, such as the model that I've described, might be an highly acceptable model for people seeking in-clinic care that could be stationed, excuse me, such that it increased accessibility in states where abortion provision is illegal post-Roe. And finally, this study is a call to continue refining measures of access. In my own work, I'm thinking about how we can improve misclassification, excuse me, improve measurement of accessibility, and also how we can incorporate multiple domains of access into individual studies. So with that, excuse me, I'll stop, except to welcome your questions and any thoughts you may have. I welcome collaboration and thoughts on how we may best measure healthcare access in the United States. Thank you so much.
Thank you for that amazing talk. Are there questions in the audience? Anyone is, oh, go ahead. Dr. Hartenbach.
Oh, sorry.
Oh, you did both.
Yeah, thank you so much. You obviously mentioned that the percentages may be more highlighted for rural women, and that's certainly something, you know, we see in our state. There, you know, as you may know, there are rural urban classification systems, and I can only imagine that the reason that the percentages aren't as large in your study is because the preponderance of women live in urban areas. But I am hopeful that you've looked at it by one of the NCHS or one of the other rural urban classification systems, and wonder if you have any comments on the differences there.
Absolutely. So let me quickly share another slide that I have. And part of why I didn't share those urban rural differences was due to time limitations today. But here are some of the results that I hope you're seeing in full screen right now.
Looks great.
Okay, great. So we used census block level urban rural definitions to examine those differences. So as you can see, this is the percentage point difference. And on the right-hand side of the screen, you can see the differences I discussed today between the TMAP ban removal scenario and the current scenario for urban versus rural. And you see that for across all 3 of the drive times, so 30, 60, and 90 minutes, rural blocks saw greater increases in accessibility than did urban blocks, likely as a result of urban blocks having higher levels of accessibility prior to this change. So we know that rural blocks are have poorer accessibility at baseline than do urban blocks. So that likely explains it, yes, but happy to share more details about those urban rural specific findings as folks are interested.
Dr. Seymour, I would love to hear how you're structuring your next research questions in a post-Roe reality.
Yeah. So it's a really great question, and I think is something that we're taking day at a time as we try to understand how and when different impacts of the fall of Roe will come into play. I think one of the things that I'm really working to understand is how does access, to Dr. Jacques' point, accessibility is one component of access. Other theorists have expanded Pinchansky and Thomas's framework to include awareness as one of the domains. So do folks know that this type of healthcare exists? And I think that's one thing that's going to become very important in a post-Roe United States, is to understand where's the confusion and what do people know about their access to care? Do they understand the laws and how they apply? Where is mis and disinformation affecting folks? So I think it's a call, again, another call to be incorporating more of these domains of access into our studies, because I think accessibility alone, while a very important measure and helpful to funders and folks who are interested in where to locate clinics, is just one part of the equation of what clients understand to be their access and how they can act accordingly. So I think we're going to really have to be thoughtful about expanding our definitions of access as the landscape changes really dramatically.
Thank you for that. Any other questions? Let's thank Dr. Seymour again. That was excellent.